This eHIV review program is presented by DKB Med Radio.
What they found is that several comorbidities, such as diabetes, hypertension, chronic pulmonary disease, neuropathic pain, frailty, depression, and a lifetime history of cannabis use disorder predicted neurocognitive decline, while their chronological age at baseline did not.
Managing HIV in an aging population. Welcome to eHIV Review. People living with HIV. More than half are older than age 50. Some have lived with the infection for many years. Others, particularly those over age 55, have been newly diagnosed. What they all have in common are the combined effects of HIV, ART, and aging bodies and minds. Cardiovascular disease, neurocognitive impairment. The risks for both continue to increase in this population despite highly effective viral suppression. How can clinicians better manage these risks? What does the current evidence say? And how can those data best be applied right now? To discuss these issues, we're joined today by Dr. Jose Lucar, an associate professor in the Division of Infectious Diseases in the School of Medicine and Health Sciences at the George Washington University in Washington, D.C. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 9, Issue 6 link. I'm Bob Busker, Executive Producer of DKB Med's e-literature review video programs. Dr. Lucar, thank you for joining us today.
Glad to be here.
Our overall learning objective for today's program is to assess factors associated with the aging population living with HIV that may complicate treatment or warrant special considerations. Our first focus is on the role statins have been found to play in the primary prevention of major cardiovascular events in older people with HIV. So that being said, if you would please, Dr. Lucar, start us out in the clinic with a patient scenario.
Of course. We have a 55-year-old man living with HIV who presents to your clinic for routine care. He was diagnosed with HIV 3 years ago. His antiretroviral regimen consists of bictegravir, emtricitabine, and tenofovir lefenamide, and reports excellent adherence. He has documented durable virologic suppression, and his most recent CD4 count was 381 cells per microliter. His medical history is only notable for hair loss, for which he takes daily dutasteride. He does not take any other medications and has never smoked cigarettes. Today, his blood pressure is 138/87. Laboratory testing shows a total cholesterol of 199 milligrams per deciliter. His high-density lipoprotein is 54, and the low-density lipoprotein, or LDL, is 135. You calculate his 10-year atherosclerotic cardiovascular disease risk at 5.9%. Recently, he nearly lost an older sibling to a heart attack. So he wants to know what he can do to prevent his own heart attacks and strokes.
How common are major cardiovascular events in people living with HIV? How does that risk compare to people without HIV?
So with the widespread availability of effective antiretroviral therapy for people living with HIV, we now know that the overall incidence of death related to HIV infection has decreased dramatically. And as people are living longer, cardiovascular disease has emerged as a very important cause of mortality in people living with HIV. The risk of atherosclerotic cardiovascular disease, which includes myocardial infarction and strokes, is known to be up to twice as high among persons living with HIV compared to the general population.
2 times the risk of myocardial infarct and stroke? Why is CVD risk so much higher in people with HIV? What do we know?
So the reasons explaining these increase really remain under investigation and are not completely understood. In part, we know that some of the traditional risk factors for cardiovascular disease are more common in people living with HIV, For example, the smoking rates are higher in people living with HIV. However, there is also a growing body of evidence that there is residual inflammation and immune activation in the setting of chronic HIV infection, which occurs despite effective antiretroviral therapy and virologic suppression. Results from large cohort studies suggest that this increase in cardiovascular disease risk appears to persist despite controlling for traditional risk factors such as hypertension, diabetes, or elevated cholesterol.
I want to ask you about a study called Reprieve. The results were published last year in the New England Journal of Medicine. Talk to us, if you would, please, about that study and what the results were and what they mean.
Of course, so Reprieve is an acronym for Randomized Trial to Prevent Vascular Events in HIV. And the reason this study was conducted is because, as we know now, that there is an increased risk of cardiovascular disease in people living with HIV. So investigators involved in the study enrolled over 7,700 people living with HIV in multiple countries around the world between the ages of 40 to 75 years old who were receiving antiretroviral therapy and were deemed to be at low to moderate cardiovascular risk, which means a 10-year atherosclerotic cardiovascular disease risk scores at less than 15% for this study. The mean atherosclerotic cardiovascular disease risk score for those participants was 4.5%. Nearly all participants had an LDL at less than 160 milligrams per deciliter, and the median was actually 108 milligrams per deciliter. And otherwise, they were not candidates to start lipid-lowering medication, in this case called a statin, by current treatment guidelines.
Doctor, let me ask you, why were they not candidates for statin therapy? What does the guidance say about that?
Yeah, so the key recommendations for the general population, including people living with HIV, are based on the American Heart Association and the American College of Cardiology guidelines, which partnered with multiple society guidelines. For example, people ages between 40 and 75 years old who have a high 10-year atherosclerotic cardiovascular disease risk estimates, which means over 20%, the guidelines recommend to start high-intensity statin therapy. Additionally, for people between the ages of 20 and 75 who have a low-density lipoprotein cholesterol at least 190 or higher, the guidelines recommend starting high-intensity statin therapy at the maximum tolerated dose. And finally, for people between the ages of 40 and 75 who have diabetes, they are recommended also to start at least moderate intensity statin therapy, and in some cases may require higher doses.
So these study participants were not candidates for statin therapy because their ASCVD scores and cholesterol readings were better than the guidance called for. Thanks for that clarification, Doctor.
So in the Reprieve study, participants were randomized to receive either pitavastatin, again, a lipid-lowering medication, or placebo. And before you ask, Bob, the reason this particular drug, pitavastatin, was selected is because it does not interact with certainly commonly used antiretroviral drugs, for example, protease inhibitors.
Thank you for anticipating my questions, Dr. Lucar. Tell us more about Reprieve, if you would, please.
Well, absolutely. The Reprieve study was stopped early after a median of 5.1 years of follow-up. And the reason for that is because the group that was assigned to take the statin drug had a 35% lower rate of major cardiovascular events, for example, myocardial infarction or strokes, compared to the group that received placebo. This Reprieve study showed that even those persons living with HIV who were at low to moderate risk for cardiovascular disease, again, in this study, defined as a 10-year atherosclerotic cardiovascular disease risk score of less than 15%, benefited from starting a cholesterol lowering drug to reduce the risk of major cardiovascular events.
What do those results mean for individuals like the patient we've been talking about in this case?
So the findings of these landmark clinical trial have already informed changes in national treatment guidelines in multiple countries, including the United States and the United Kingdom. Earlier this year, in February of 2024, the United States Department of Health and Human Services panel for the use of antiretroviral agents in people living with HIV updated their guidance and now recommend starting a moderate intensity statin for the primary prevention of atherosclerotic cardiovascular disease in people living with HIV between the ages of 40 and 75, with a particular emphasis in people whose 10-year atherosclerotic cardiovascular disease risk score between 5 and 20%. The reason being that this is the group that appears to have the higher benefit. Prior to these updates, the guidelines essentially recommended the same approach for people living with HIV as for those individuals living without HIV, since we did not have findings such as the ones from the REPRISE study to inform such decisions.
So, to clinicians treating aging people with HIV, what would you advise them about discussing the potential benefits and risks of statin therapy use with their patients?
Yeah, so like these 55-year-old men living with HIV that we've been discussing, the risk of cardiovascular disease will remain higher than compared to someone without HIV, despite effective therapy and viral suppression. It is very important to always discuss general prevention strategies, including exercise, smoking cessation for those who do smoke, diet modification, and if needed, weight loss strategies, as well as optimal control of comorbidities, including hypertension and diabetes. Now, if a patient's ASCVD 10-year risk score is in the moderate range, which again, for this study was between 5 and 15%, I would recommend starting a moderate intensity statin. Now, it's also important to know that in the REPRISE study, the incidence of diabetes was slightly higher in the group that received pitavastatin compared to placebo. However, the incidence rate overall appears similar to that of the age-matched general population. Additionally, muscle-related symptoms are seen also in people taking statins, and that's been well described in the literature. In the REPRISE study, they occur in similar rates in both the pitavastatin group and placebo, but nevertheless, patients should be informed of these potential risk so that they can monitor for development of such symptoms.
One more question about this case, Dr. Lucar. In your own practice, have you made changes based on the REPRIEVE results?
Yes, this trial has changed my practice. And now, particularly for people between the ages of 40 and 75 years of age who are living with HIV and are at moderate risk for cardiovascular disease and are otherwise not a candidate to receive statin for other reasons, I recommend starting a statin in those instances. Now, for those individuals at lower levels of risk, such as people who have an ASCVD 10-year risk score of less than 5%, I make sure to inform them of the results of this study and have a shared decision-making process depending on their individual circumstances. If pitavastatin is not available, I think it's reasonable to replace it with a different statin, such as atorvastatin or rosuvastatin. However, paying close attention to potential drug-drug interactions, for example, with other antiretroviral agents, such as protease inhibitors.
Our focus for this part of our program is to describe the role statins have been found to play in the primary prevention of major cardiovascular events in people living with HIV. So, summarize for us, if you would please, Doctor, the most important points from our discussion you'd want our learners to take back to their practices.
First, people living with HIV have up to twice the risk of atherosclerotic cardiovascular disease compared to the general population. Second, this risk is not just explained by the presence of traditional risk factors for cardiovascular disease, such as hypertension or diabetes, and it does not appear to be eliminated by effective antiretroviral therapy and viral suppression. Third, we need primary prevention strategies that are tailored to this population, not just wait until events occur. Fourth, the REPRISH study investigators found that in people living with HIV between the ages of 40 and 75 who were on effective antiretroviral therapy, pitavastatin, a lipid-lowering agent, was associated with a significantly lower rate of major adverse cardiovascular events, such as myocardial infarction and strokes, a risk that was 35% lower than those who received placebo. And finally, this study results suggest that statin therapy could reduce the risk of cardiovascular events in this population, not only through lowering LDL cholesterol, but its effect may be mediated by reducing systemic inflammation levels, as has been suggested by previous studies.
Nice summation, Doctor. And we'll return with Dr. Jose Lucar from George Washington University in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program, focused on the management needs of individuals aging with HIV. We've been speaking with Dr. Jose Lucar, an infectious disease specialist from the School of Medicine and Health Sciences at the George Washington University, about the need for HIV care providers to take into account the role statins have been found to play in the primary prevention of major cardiovascular events in people living with HIV. Let's turn now to our second focus, the prevalence of neurocognitive decline in the aging population living with HIV and its association with comorbid conditions. So if you would please, Dr. Lucar, take us back to the clinic with another patient scenario.
Absolutely. We have a 59-year-old woman living with HIV presenting to your clinic for routine HIV care. She was diagnosed with HIV in the 1990s. She was documented durable virologic suppression, and her most recent CD4 count was 567. Her antiretroviral regimen consists of dolutegravir and rilpivirine, and she reports good adherence, but occasionally misses doses due to forgetfulness. In fact, over the past 3 years, she has noted memory issues that seem to be getting worse. After undergoing neuropsychological examination, she's found to have difficulties related to word finding, short-term and prospective memory, attention, and overall speed of information processing. As an example, she frequently loses her train of thought and has difficulty navigating computer programs that were previously familiar to her. She lives alone and independently manages all her daily activities, which include working full-time. Otherwise, the patient feels well overall. She has no headaches, fevers, or recent illnesses. She has a history of hypertension. Her blood pressure today in the office was 165/94, for which she takes hydrochlorothiazide, and depression, for which she has never received treatment. She denies regular use of cigarettes, alcohol, or recreational drugs.
Neurocognitive decline in older people living with HIV. How common is that? And how does that risk compare to people of the same age living without HIV?
In the era of effective antiretroviral therapy, the incidence of the most severe form of neurocognitive decline also known as HIV-associated dementia, has markedly decreased. And in fact, in the recent years, the risk appears similar to the one seen in the general population. However, the prevalence of mild neurocognitive disorders in people living with HIV remains high even despite virologic suppression. A recently published meta-analysis estimated a full cognitive impairment prevalence of about 40% among people living with HIV globally and has ranged between 20 to 70% in various studies. Whether mild neurocognitive disorders are more common in people living with HIV compared to those without HIV remains to be determined given the results of different studies.
The patient you presented, a 59-year-old woman, what can you tell us about her risk factors for developing neurocognitive decline?
So this is a person living with HIV who is older than 50 years of age, a group that has an increased prevalence of neurocognitive deficits compared to people younger than 40 years old. I would like to know more about her HIV diagnosis history as well as her treatment, as there is a potential association with a lowest historical CD4 count, also known as the nadir CD4 count, in addition to the duration of HIV infection in her case, with an increased risk of neurocognitive impairment. A recent study used data from a US-based multi-center CNS HIV antiretroviral therapy effects research, also known as the Charter study, which was designed to explore the evolution of HIV-associated neurological complication in the context of antiretroviral therapy. Participants involved in this study underwent comprehensive neuromedical, neurocognitive, and laboratory assessments at baseline and 12 years later. And so authors compared those changes in neurocognitive function in individuals who were older at follow-up, at least 60 years or older, versus those who were younger at less than 60 years of age. Interestingly, what they found is that several comorbidities, such as diabetes, hypertension, chronic pulmonary disease, neuropathic pain, frailty, depression, and a lifetime history of cannabis use disorder predicted neurocognitive decline, while their chronological age at baseline did not. This was, in a way, a surprising finding, considering that age itself is considered a risk factor for neurocognitive decline.
Comorbidities predicted neurocognitive decline, but not chronological age at baseline? That really is an interesting finding. What else do the Charter results tell us?
These important results underscore the importance of prevention and optimal management of comorbid conditions in people living with HIV to prevent and manage neurocognitive decline. There should be increased attention to these common comorbidities in people living with HIV and should be addressed to optimize outcomes. Now, this should include reducing cardiovascular risk, the control of blood pressure, treating elevated cholesterol, smoking cessation, appropriately managing diabetes, and maintaining a healthy weight. We know that additionally, activity and exercise appear to have some cognitive benefits as well.
Take the last word, please, Dr. Lucar, about support for people aging with HIV.
Overall, the care for people living with HIV is improving, and as such, people all over the world are getting older with HIV. In fact, according to data from the CDC in the United States, of the nearly 1.1 million people living with HIV in the US in 2021, about 53% were aged 50 years and older. Older adults with HIV not only have an increased risk of developing comorbid conditions, but also certain clinical conditions that we see in older adults that do not fit specific disease categories. For example, frequent falls, incontinence, dizziness, and overall functional decline. The care of older people with HIV has to include their functional, social, environmental, psychological, spiritual, and goals of care status. Finally, I want to make a point about polypharmacy, which is the use of multiple medications by a patient, as it has been associated with multiple potential complications, including decreased physical and cognitive capability. So it is key to reduce inappropriate medication use.
Thank you, Dr. Lucar. Our focus for this part of today's program is to discuss the prevalence of neurocognitive decline in the aging population living with HIV and its association with comorbid conditions. What are the key things you'd want our learners to remember?
First, people with HIV are living longer. Second, changes in memory, concentration, attention, and motor skills are common in people living with HIV, all of which is collectively referred as neurocognitive decline. Third, while there has been a significant decrease in the prevalence of the most severe forms of neurocognitive deficits, the milder cognitive deficits remain common in the setting of HIV infection, even among people with virologic suppression. Fourth, there are several risk factors for neurocognitive decline in people living with HIV, including comorbid conditions such as cardiovascular and metabolic diseases. And finally, prevention and optimal management of comorbid conditions in aging people with HIV is key to minimize and prevent further neurocognitive decline.
From the Division of Infectious Diseases in the School of Medicine and Health Sciences of the George Washington University in Washington, D.C., Dr. Jose Lucar, thank you for sharing your knowledge and expertise in today's eHIV program.
Thank you for having me, Bob.
For eHIV Review, I'm Bob Busker.